Hello, my name is Bruce Strober. I'm a clinical professor of dermatology at Yale University. I also practice at Central Connecticut Dermatology in Connecticut. And my passion is to take care of patients with psoriasis, whether it's systemic appropriate or people who just need topical therapies. I really enjoy all types of psoriasis patients. I pretty much have about 3,000 patients with psoriasis currently. And interestingly, I just scanned my electronic health record. Approximately 400 of those are on Risankizumab, which speaks to my affection for this particular biologic for psoriasis. Risankizumab really is a revolutionary drug because it's applicable to most patients with psoriasis that's systemic appropriate. By that, I mean people who don't do well on topical therapies, who aren't candidates for topical therapies. And really, the best patient is the most common patient who's systemic appropriate. That's the chronic plaque psoriasis patient who has what was seen in the clinical trials, trunk, extremities, scalp. If you give a newbie patient who's never been on a systemic therapy any drug, I think risankizumab should be at the top of the list. It's really my first line biologic. And that's basically because there really aren't contraindications to its use. It essentially can be given to most any moderate to severe systemic appropriate psoriasis patient, regardless of their comorbidities. They could have inflammatory bowel disease. They can be people with liver disease. They can be people with kidney disease. They can be people with cardiac histories. There's really no reason not to give risankizumab. And then, predictably, the drug clears patients, and really in a relatively short period of time. While it's not the fastest biologic, it certainly shows efficacy even after the first dose and waiting 4 weeks. And then they're off to the races every 12 weeks thereafter. Generally well tolerated, does not need blood tests. So from that point of view, it's really easy for patients and easy for you. And then what I most commonly hear from patients in follow-up is the word miracle. People describe this drug as a miracle because of how easily it is for them, how well it works, and how well they feel on it. Now, specific types of patients, particularly those with high impact site involvement, like scalp, palms and soles, genitals, are really good candidates for risankizumab. And therefore, even a person with bad palms and soles or bad scalp, I usually use risankizumab first line because it gives a high probability of success even in these tough to treat patients, albeit you might want to counsel them that it could take a little longer to see their full efficacy, particularly palms and soles, 6 to 12 months of therapy before you see the full efficacy. And then there's the patients who have a measurable amount of psoriatic arthritis. And these are people, of course, who have a significant amount of skin disease, but they have detectable psoriatic arthritis, which, of course, everyone who sees psoriasis patients should screen for at baseline. And patients with psoriatic arthritis who are put on Skyrizi commonly do better. And note their joints and ligaments feel less symptomatic. And interestingly, people who really didn't think they have psoriatic arthritis, who you think just have run-of-the-mill psoriasis, and you put them on risankizumab, well, 6 to 12 months later, they're telling you their joints feel better. And they just feel better in general. So here's an instance where risankizumab uncovers psoriatic arthritis and improves patients beyond simply improving their skin condition. So there are a large variety of psoriasis patients, and basically most every type of psoriasis patient who I feel risankizumab becomes a very, very appropriate first line therapy. And so you talk about do we switch people to risankizumab? Well, there are instances where I do that, but because it's usually my first line drug, I don't commonly have to switch people to it. I switch people off it if they aren't responding to it. But it's really the perfect first line systemic. And then I just like to close by saying there's quite a few patients who would not get into clinical trials for psoriasis because they have too low a body surface area of involvement, perhaps 3 to 10% BSA. And if you were to do a PASI score, it would not allow them into the clinical trials. It'd be less than a 12. Yet Risankizumab becomes a perfect drug for that patient too, who's got topical therapy fatigue. The topicals either aren't effective or just too much for them to do every day. And you put them on risankizumab, and that patient clears as well. So I would encourage the use of risankizumab in pretty much all types of psoriasis patients, regardless of BSA involvement, especially if that low BSA patient just isn't right for topical therapy, has voiced it. I had a patient come in this week alone who said to me, I have had psoriasis, new patient, I've had psoriasis many years, elbows, knees, a little bit in the scalp. You really couldn't amount his psoriasis to more than 5%. And I immediately said, because he was new to me, well, why don't we try a topical? And I was thinking of a non-steroidal topical cream that's available. And he immediately cut me off and he said, I've had enough with topicals. I really want to go to the next level. And I said, all right, perfect. I'm completely on board with that. And why don't we start risankizumab? And I gave him the data and some of the potential adverse effects that can occur, which is primarily just infection and low rates of that. And I told him, how we dose it, and he signed up, figuratively for this therapy, and we gave him his first dose in the office right there because we have samples. This patient was really an extreme example of a patient who just basically walks in and says, I've had enough of topicals. But I think a lot of our patients have had enough of topicals. And for that reason, you should inquire, have you had enough of topicals? And would you be willing to try a systemic therapy that I think is safe and much easier for you? All right, so that's my summary of how I use risankizumab. It's full service. I don't think it's easily going to be supplanted by other therapies because of its infrequent dosing and its predictably good efficacy. It's really solid tolerability and the lack of need for blood testing while you're giving patients this therapy.